So what I was asked to do is say something about global health during a pandemic. Now, obviously, we are during a pandemic. So I thought a little bit about it and then thought, well, since this is a program for internal medicine scholars and physicians, I thought maybe say a few words first about global health as a discipline, then a few words about pandemics, and then we've sort of covered the definitions, and then move into the obvious one, which is the COVID-19 pandemic, and discuss a bit its impact on global health, a few words about the epidemic response and what we currently see across the world and what seems to work and what doesn't seem to work. And obviously the thing that we're all thinking about now, what about a vaccine? So to start with global health as a discipline, there is a definition for global health that's often being used, and that's the following. That's an area for study, research, and practice that places priority on improving health and achieving equity in health for all people worldwide. And the way global health approaches this is by being transnational, meaning that it focuses on health issues, on determinants of those issues, and also solutions for those health problems that transcend national boundaries. So it's about things for which that are international in their origin, for which international collaboration is very important. A second characteristic of global health is that it is interdisciplinary. It involves many disciplines within and beyond the health sciences, and they collaborate in an interdisciplinary way. I'll say a few more words about that. And then finally, it is integrated as a synthesis of population-based prevention, which is more the classical public health approach, with individual level care. So it brings the previous notions of, at least from a European perspective, of international health and what was at the time tropical medicine sort of together, but then even with a broader scope. Now, with regard to the transnational element, I think another way of framing this is that it is very much about health consequences of globalization. Now, globalization is defined, and this is the Elbro and King definition, which I like, as all those processes by which the peoples of the world are incorporated into a single world society. And a distinction that's often made is between economic globalization, cultural globalization, and political globalization. They obviously hang together. And each of them has several ramifications, implications for health that are relevant and are being studied in global health. Just to give you a few examples. So international trade and multinational companies moving their production to low-income countries obviously leads to economic disparities and thereby health disparities. This is the one we are currently looking at. That is the tremendous effect that international travel, especially air travel, has on the spread of infectious diseases. And another one that's very, very obvious, that is the whole problem of environmental health and climate change. Cultural globalization is really about sort of the cultural aspects that are sort of spread around the world. And one example of cultural globalization having an impact on health is the global spread of fast food, which clearly has consequences with regard to obesity, cardiovascular disease, and so on. Another example is the spread of what I call medical consumerism, the over consumption of antibiotics, leading to a vast increasing rate in antibiotic resistance. I think with regard to infectious disease threats, up until maybe January this year, everybody was talking about antimicrobial resistance as being the biggest one for the years to come. Now, obviously, it's COVID-19, but it's still there. Now, another one is the huge spread and increase of internet on all sorts of devices, and that has all sorts of effects on health. Several of them we don't know yet, but we can expect that they will come. For example, I've already mentioned use of fast food, but also other things that, for example, people all around the world are now exposed to the same which I think are basically just advertisements, and will probably move to doing things that may not be very good for their health. Now, political globalization also has ramifications for health. One, for example, are the TRIPS agreements, which are under the World Trade Organization and put certain requirements and limitations on the free accessibility to drugs, or the free availability of drugs because of intellectual property, which actually has effects on health disparities worldwide. We're also seeing positive effects here, the fact that countries are working together, not all of them, but at least a large number of them, has potential sort of positive consequences for solving some of our major problems, such as climate change. And we are seeing a very interesting, we've seen it over the past 10 years, a very interesting shift from funding for health at the global level, from government agencies or multilateral agencies, to individuals. People like Bill Gates, I mean, obviously had a tremendous contribution to solving, to at least technological solutions for a number of global health problems. But the interesting thing here is that probably because he's doing all that work, it probably also means that others can crowd out, so that there will be less inclination of governments to fund these kind of activities. And obviously, Bill is not under democratic control. So it's an entirely different playing field here now. With regard to interdisciplinarity, this is just showing you the Sustainable Development Goals, as you will probably know. And there is no way in which you can study health at the global level if you don't take into account several, if not all, of the other SDGs. It's clear that talking about health without talking about poverty worldwide it doesn't really lead to sort of the actionable conclusions. Same is true for nutrition, for education, for gender equality, for other types of inequalities, for sustainability in the living environment, climate, and so on and so forth. Meaning that global health is essentially an interdisciplinary field. For example, in our little institute, we work together with people from 2 universities. They're in clinical medicine, they're an epidemiologist, they're microbiologists, they're anthropologists, they come from political sciences, they come from economics, they come from law, and we're trying to pull in people from engineering, from artificial intelligence, and so on. So all these disciplines are important. Now, the approach of global health is very often, it's not all we do, but it's a very important one, and you'll see a little bit more of that later on in the presentation, is to look at countries and settings and compare them with regard to health status and health outcomes. and then try to understand what the drivers are of that variation, because that can tell us a lot about what the problems are and how they could potentially be intervened. And then finally try and find global solutions that then need to be obviously tailored to local needs. And that is, and to me, these are the three important things. And obviously then you have to test those solutions in several settings. That's basically what we do in global health. So now let's move to pandemics. So of course, the first question is, what's a pandemic? And by the way, I hope you will all have at some point in time the opportunity to read William McNeill's magnificent work dating back from the 1960s, already, of Plagues and Peoples, where he actually sort of redrew the history of mankind by infectious diseases, which to me was a real eye-opener. When I read this, I thought, oh gosh, I'll go in infectious diseases. I love this. So a pandemic is the worldwide spread of a new disease. Why do diseases spread worldwide? Because most people do not have immunity to that pathogen. Once they have, it will not anymore be a pandemic. We'll usually call it an endemic or something like that. Now, how is that enhanced? It's enhanced, I think, by three major issues. One is increased global contact. Warfare has historically been very important, travel and trade. It's enhanced by high transmissibility, obviously. I mean, if there's little transmissibility, there's no pandemic, there's no global spread. And I think importantly, unnoticed transmission, and we'll look a little bit more into that with regard to COVID-19. So a few examples of pandemics. I think the one that's historically the one most well known is the bubonic plague, and especially the Black Death, which was the first epidemic in Europe. I tend to call it a pandemic, but I think that's very Eurocentrically thought, but still I think much, at least for Europeans, it was really a pandemic because it affected all countries. And interestingly, it actually, let me see if I can pull up my laser pointer. Interestingly, it came with the Mongolian warriors across what now is the Russian steppe, up to the Black Sea, where it actually, because this is transmitted by lice, so it's Yersinia pestis, as you will know, transmitted by lice, and the lice live on rats. So these were the rats that were in the grain that was in the that was brought by the Mongolians, then onto the ships. The ships moved it basically across the whole Mediterranean to major ports such as Venice, Genoa, Barcelona, and so on. And from there, it spread back over land. And together, the estimated death toll of this pandemic was 75 to 200 million, probably the biggest the world has ever seen. Another one was the second cholera pandemic. That has a very interesting history. You probably know there have been 7 pandemics now, and this was the second in the first half of the 19th century. And that was, as all cholera pandemics, they actually originate from the Gulf of Bengal. And that was actually carried by British troops by their various warfare activities, the various expeditions. For example, also into Egypt and also into the United States and Middle America during the wars of independence. The estimated death toll there was obviously much lower because cholera is much less of a mortal disease in adults than it is for example, plague. I think the pandemic that is still the one sort of most known to people before COVID-19 was the Spanish flu. It was influenza H1N1, an epidemic that spread across the world during 3 years from 1980 to 1920. With an estimated death toll of 50 to 100 million. So that was really huge. And these are, I think by now, these are again pictures that are familiar to us. Now, as all influenza, its origin was in China. It spread to the United States, but still sort of kept below the radar. Then had some sort of an amplification in military barracks preparing for going to the front in the First World War in France, moving with these troops to France, and then really in the trenches in 1918. At the end of the First World War, that was probably one of the places where the Spanish flu was really sort of amplified. And these troops then, after the ceasefire, went back home. And they brought influenza back. And this is probably one, it's not the only one, it's probably one of the ways in which influenza spread rapidly across the world. Now, it's interesting to realize that most epidemics don't make it. So these are outbreaks. An epidemic is defined as an occurrence of disease that is clearly in excess of the expectation. That's the Benison definition. So most epidemics actually don't make it into pandemics, and that's interesting. For example, take SARS. SARS is the best known predecessor of COVID-19. It's a virus from the same group. It spread, so it stands for severe acute respiratory syndrome. So with regard to clinical presentation, pretty much like what we currently see in severe COVID-19. It spread from China, where it also originated, to a number of other countries. But as you can see in the numbers here, the total number of confirmed cases was 8,000, with 74 deaths. It actually got extinct within a year, with most cases still in China, but actually relatively few cases in other places of the world. And that may be because SARS was mainly transmissible during its severe symptomatic stage. And people who had severe symptomatic SARS were confined to bed, probably confined to a ventilator, so they were not really capable of transmitting outside of their hospital room. Of course, there are a few examples, such as the famous Guangzhou internist at the conference in Hong Kong, who I think infected 100 others and died two days after that. Another, I think, very interesting example is the Ebola epidemic in West Africa that took place from 2013 to 2016. That was actually the largest epidemic ever seen, with almost 30,000 confirmed cases, over 11,000 deaths. Interestingly, before that, there had been Ebola outbreaks in Central Africa, quite a few, mainly confined to villages, small towns, etc. And I think the biggest number in an outbreak that had been seen thus far, before 2013, in the Congo was around 300. Now, all of a sudden, we were looking at 30,000. Now, one of the explanations for that is, so there are two things here. One, strangely enough, all of a sudden it was a big epidemic, but the big epidemic didn't make it into a pandemic. Now, one of the probable reasons why it became such a big epidemic is that in Ebola, people are infectious during their symptomatic stage. But the problem is they're also infectious after death, because there are very high levels of virus in their sweat. And interestingly, in West Africa, we also don't know that from previous cholera outbreaks, there are burial rites that involve very close contact with the corpse. And that's probably the way that it's spread. There have been a number of instances of spread during burials that involved hundreds, if not thousands, of Ebola patients. And only after this was sort of, people realized that this was the issue, and after safe burial practices were introduced, the epidemic curve came down. It's a very interesting thing. So it means that, and since dead bodies don't travel, I think that is the main reason why there was no global spread for Ebola. We'll come back on that on COVID-19. Now, a few words on what's happening with all these new viruses or new pathogens. Now, they come from the animal world. That's the only place that they can come from, but because the ones the ones that come from humans, we already know by now, and most of them, almost all of them, I think. So they come from the animal world, and this is just looking from 1960 onwards. Human outbreaks due to new pathogens. We've seen that for several hantavirus species. There are viruses of rodents, New influenza variants, obviously, Machupo that causes Bolivian hemorrhagic fever, Marburg, Ebola, HIV, obviously, Hendra, that's a virus infection of horses, Nipah, a virus infection of pigs, and then obviously SARS, MERS, which is the Middle Eastern sort of variant of SARS that for which we have an ongoing outbreak, but that hasn't really been very large, and now obviously SARS-CoV-2. So there is spillover apparently from the animal world, and this is a book from a couple of years ago, but I can still recommend it. It's really a very good read on these various spillover events. And probably there are many more spillover events that don't make it into epidemics, let alone in pandemics. But every now and then, if there is a sort of perfect storm, these things happen. And they happen increasingly for a number of reasons, which have to do with ecology, the way we as humans sort of intrude into the space of animals in forests in other ways. And one interesting thing about these viruses is that bats are important reservoirs. They're not necessarily natural hosts, but they're important reservoirs. And that has to do with the fact that bats can sustain very high levels of viremia without becoming ill. It's actually very interesting why. People don't really understand, but there seems to be a link with the fact that they also don't have cancers. So bats are a very special kind of mammals. They're mammals, and bats make up 20% of all mammalian species. And as you can see here, there's a whole list of them. The important one for us now is the Chinese horseshoe bat. That is a reservoir for SARS-like coronaviruses, including COVID-19. And another one is the African fruit bat that is a reservoir for Ebola virus. And this has always been part of the human imagination. Obviously, we know Batman, which is the good guy, but also there's the bad guy. This is of Bram Stoker's famous novel Dracula. And they have a point. I mean, at least Bram had a point. I mean, bats are dangerous animals to humans. And probably there's a tremendous lot of other viruses that we don't know of that are sort of sitting there waiting to jump. So they probably come from animals. They live happily in bats, waiting for them to jump to us humans. So just to give you a glimpse of what that can look like. So this is what we know from these, I think, very interesting cycle of transmission of Ebola virus. So we know that Ebola virus has these African fruit bats as a reservoir. These bats, I mean, obviously they
Congelou.
Frozen?
Yes. Vamos aguardar.
Can you hear me all right?
Yes.
Yeah, sorry, my connection dropped.
Okay. I think you'll have to open the presentation again.
Yeah. Can you see the presentation? No, I have to share screen again? Yeah, I probably have to share. Let me just do that. And then, there we go. Sorry about that. Probably has to do with the rain here. Every now and then we get difficulty then with the connection.
So we followed until you were talking about the bats among them, and then we lost you.
Okay, good. So
Maybe a bat interfered with the.
I hope not. So let me see. So can you see full screen now?
Yes.
Okay. So I started to talk about Ebola virus transmission cycle as an example of how this could work. So what we know, let me bring out my pointer again. So Ebola, there are a number of subtypes of Ebola viruses. This African fruit bat is its main reservoir. These fruit bats, they feed on fruit. That's why they're called fruit bats. But every now and then they bite for example, gorillas or chimpanzees or other large animals. And these get ill from Ebola, they die, and then they may their meat may be eaten as bushmeat by people by villagers, and then that can be the start of a transmission cycle amongst these people. And especially if they are admitted to hospital, you get within hospital transmission. That very often ignites a local outbreak. And there are actually also instances known about which people directly eat bats. Probably the starting point of the West Africa epidemic was a child that ate a not too well roasted but hopefully tasteful bat. It's probably patient zero of that outbreak. So and this obviously can happen much more often. Now let's move to the COVID-19 pandemic. That obviously started in Wuhan in China. We don't know exactly how, whether there was really an intermediate host. It most likely comes from that Chinese horseshoe bat. Those Chinese horseshoe bats were probably also sold as delicacies at that market. But that's still sort of in the works. And this is from last week, I think. Yes, this is the Johns Hopkins Coronavirus Resource Center. If you haven't been there, you should go there. It's a wonderful resource. And it shows us the total global cases. We are running up to 13 million now. We have a number of global deaths close to 1 million. And you can see so where these outbreaks are. You can do all sorts of fancy things with it. It's very nice. But obviously what we want to look at is its spread. So now, interestingly, in the beginning of the epidemic, so there was the first 2 months, almost all of the spread came from China. So there was first spread within China, and in January, obviously also during the Chinese New Year, when people go back to their home villages. And you can also see that most of the spread was from China to Europe and to the United States. If you look after that, the subsequent 2 months, almost all the spread was from those areas. So it really had become a pandemic. So it was not anymore China that was spreading this epidemic. It was really the United States, Europe, and to some extent Australia, from which it was spread, amongst others, obviously, to Brazil and other parts of South America. It's interesting to look at the case numbers worldwide and its pattern over time. This is from a paper that I really liked, and I have to like it because he's a colleague of mine in Amsterdam. Joost Giersinga put out this paper, like I think 2 or 3 weeks ago in JAMA. Gives a very good clinical overview. I'll use a few more pictures from that. So this is a picture that shows the case rates, and you can see here, this is the Western Pacific, that's the region, WHO region that China's in. So there were cases here, and then it sort of dies down, and then after a couple of weeks, we see cases really come up, initially in Europe, which sort of died down a little bit after April, May, when the lockdowns started to get effect. And we also see it in other WHO regions come up, but the region that is really truly affected is the region of the Americas, as you will have noticed, both North and South America, for reasons to some extent known, for reasons to some extent unknown. Interestingly, it's very low still in Africa, and we don't know whether that is just underreporting of cases, of deaths, or that there are other things at play, for example, a different age distribution, or potentially a different immune response. Now, this is for you probably known, but just do it very quickly. So SARS-CoV-2 belongs to the coronaviruses, which are viruses of various mammals and birds. There are large single-strand RNA viruses. There are 4 known coronaviruses in men. They are called seasonal coronaviruses. They cause upper respiratory tract infections. They usually come back every year, every 2 or every 3 years, and they are ubiquitous. We see them all over the world. And one of the hypotheses is that they all started a bit like SARS-CoV-2, and then over time made it into something that is endemic or is sort of epidemic, but as a mild disease. More recently, we've seen SARS, MERS, and then COVID-19. They're all spread by the respiratory route. This is basically how it works. So this is the virus. It binds with its spike protein with through a sort of intermediation of this TMPRSS2 receptor to the ACE2 receptor, which it then cleaves, and that causes the binding, and then the virus gets in through endocytosis, starts replicating using the cell's machinery, and then out come the variants. So basically, that's how viruses do their job. If you look at the pathogenesis, we know that there is early stage infection, which often involves the lungs and then causes a sort of a viral pneumonia of different clinical extent. In this stage, it's really the viral replication that dominates. Then in late stage infection, it's really the inflammatory response that dominates, which then often leads to pulmonary edema and adult respiratory distress syndrome. But then in severe cases of this late stage infection, can also make it into what people have now coined as viral sepsis with intravascular coagulation, multi-organ failure, which is very often the cause of death. And I'll come back to clinical and subclinical ratios later on. Now, I think it's one of the very interesting, but also I think scary characteristics of this virus is if you compare it to SARS. So this is the cause of infection. So here we have the point of infection, incubation period, symptom onset. Now starts viral disease, and then the complications start in SARS. Viral shedding you only see starting after symptoms have started, and people are often already pretty ill, as I said. Now in COVID-19, by now we know that viral shedding generally precedes the onset of symptoms by 2 days. And actually the peak levels in the nasopharynx are in the first 2 days, which means that, and that's what we now have seen, that probably 1/3 or even up to 50% of transmission is due to this the pre-symptomatic shedding. So these are really the dangerous people, which explains a lot of the, I think, of the transmission, also of why this so easily became a pandemic. People thought, probably also in Brazil, but here in the Netherlands in the beginning, we don't have to worry. We know how SARS works, so we don't have to worry too much if they don't have disease, they're not infectious, and it turned out to be not true at all. So that was actually the reason. There was already many infections under the radar and transmission under the radar, because we started noticing something, which was probably a reason why we had these huge peaks of transmission early on in Europe. Now it's clear it's a fascinating disease in terms of its clinical to subclinical ratio and its mortality, because it is a very strong association with AIDS, which we basically do not understand. Now, this is data from, it's a very nice way of displaying it by CDC. They took 80 to 29 years as the comparison group and then said how much lower it is in the low. You can see this is for hospitalization, pretty much lower in the younger age groups, pretty much higher in the older age groups, goes up to about 10 times higher in the age group of 75 and over. But for death, that is even more pronounced. It's actually a lot more pronounced. And so you can see you're looking at already 100 times higher death rates compared to the people, where in Europe we currently see the transmissions basically in the students. So students, be careful with your faculty, especially if they're over 65. They have a 100 times higher risk of dying from this disease than you have. Another thing that is, I think, is intriguing is the it's the consistent association with comorbidities, and some of them which we don't understand at all. Like you see here, for if you have hypertension, you have an increased risk of hospitalization due to COVID-19 of about 3. Same for diabetes, asthma slightly lower but still increased. also increased for chronic kidney disease, increased for obesity, especially for severe obesity, which may have to do with ventilation problems. And if you have combinations, that risk even goes up. So it's very clearly associated with comorbidities. And what we also see, it is associated with disparities. And there have been several studies. I'm just showing here data from 2 studies from the US, where they basically looked at the proportion of Black patients that were hospitalized with COVID-19 and the proportion of Blacks in the population. So this is the proportion hospitalized with COVID-19, proportion Blacks in the population. And it is 2 to 3 times higher in the hospitalized population, which tells us something about disparities. We don't know whether that is whether that relates to infection risk, whether it relates to risk of severe disease, what the underlying mechanisms are, but it's a very important thing to take into account. Now, a few slides on the impact on global health of this epidemic. Now, there is a clear impact first of all, on mortality. This is again from the Johns Hopkins site. You can look it up, it's updated daily. This gives mortality as rates per 100,000. And there is, I'll come back to this later, but there's something striking is that especially in countries in South America, these mortality figures are very, very high. So that's really food for thought. But what it's meant to show here is that there is very high mortality, obviously. There is, and I mean, it may have to do with age distribution, may have to do with comorbidities and so forth, but perhaps but also with things that we still don't understand. But obviously it has a great impact on morbidity, clearly in those vulnerable populations, the elderly, the ones with comorbidities. There are increasing reports of long-term sequelae of COVID-19. Respiratory disability is definitely one, prolonged weakness is one, organ dysfunction, and there is also increasing evidence of mental health problems both during disease and during reconvalescence. I think another very important sort of group of direct effects is those that are signs of reinforcements of social disparities. Like the poor obviously have poor housing, may be homeless, obviously have crowded living conditions, may have crowded conditions at home or have to use public transport that's crowded, may even have a poor immune response, and thereby they are at risk of increased, clearly at risk of increased risk of infection. The physical environment probably plays a role. Smoking seems to impact on the risk of severe disease. Smoke exposure potentially also. There have been suggestions from studies from northern Italy that air pollution might play a role as well. And obviously, the poor are usually also the ones that are most dealing with these environmental issues. The poor have generally poor access to healthcare, leading to higher risk of severe morbidity and death, and to health communication, which makes it more difficult for them to prevent infection. They more often have underlying conditions, especially true for COPD, diabetes, and obesity. And we've already touched upon this race or ethnicity association, which may actually be a combination of all these, but potentially also something that is more genetically defined. In addition to these direct effects, there are clear indirect effects, and I've categorized them into 2. One, overburdened health systems, poor access to medical services, less attention for other health problems. I think it's a major problem. At least we have seen it as a major problem in the first months in the Netherlands. And obviously disease and deaths among healthcare workers, which I think you've particularly suffered from in Brazil. But obviously there are also effects of the containment measures, the lockdowns. These are mental health problems, problems with violence, economic losses, very important, especially in poor environments, leading to reduced access to quality care and worsening health status. I'll give a couple of examples, just a few. this is from a systematic review, very interesting, that looked at mental health effects. And they looked at, not at people who were diseased, but they looked at the general population during the COVID-19 in this pretty broad range of countries. And what they found was that obviously that's interesting by itself. There was quite a diverse range, pretty high, large range. This is the minimum, this is the maximum estimate. Pretty large range in the prevalence of these mental health conditions, but the higher estimates are really pretty high. For stress, it was around 90%. For post-traumatic stress disorder, depression, and anxiety, it was around 50 to 60%. So it's really pretty high. And the risk factors associated with these distress measures were presence of chronic or psychiatric illness, so sort of pre-morbid conditions, but also female gender, young age, unemployment, being a student, I think very important, and frequent exposure to social media and news concerning COVID-19. So probably a combination of exposure to all sorts of things, but also to personal circumstances. And we notice, I don't know how it is for you, but we notice now already, even though we don't have a full lockdown, that students are tremendously lonely, which then also has its consequence for students coming together and then has its consequences for spread of the epidemic. And this is data from our own institute, from Wendy Janssen, who is a development economist, and she had an ongoing study in 350 rural households in Kenya, where she collected data on a bi-weekly basis on people's what they call financial diaries. So they looked at at all sorts of things around their income and their expenditures. And I think this is quite unique data because they had set it up using cell phones. So by the time COVID hit and the lockdowns were introduced, they could actually just continue doing this work. So what they showed is that there was a decrease. So this is from before the lockdowns. And then here we have over a period of almost 3 months of lockdowns. And then we see that there is a clear decline in these households' income, especially in gifts and remittances that they depend on. For example, relatives that live in the city or even abroad. And you can see this is their expenditure. You see that the expenditure on education goes down, which may actually be due to the lockdowns themselves, that schools have closed, but we also see a very clear decline in medical expenditures, which I think is proof of crowding out of medical services that people need, otherwise they wouldn't spend their money on it, because of the lockdowns in the COVID-19 situation. And so this has major consequences potentially. And this is, apologies that this is a lot of text, but I put some things from reports together because I think there are pretty scary projections with regard to the effect of COVID-19 on malnutrition in children. As you can see here, early the estimation early in the pandemic was that there was a 30% overall reduction in the coverage of essential nutrition services, and in lockdown context in Africa that even went up to almost 100%. That in a study of 180 lower middle income countries, there was a potential 14% increase in moderate or severe wasting among under 5 children due to losses in gross national income per capita. And the projections based on these data and other data, amongst others from the World Food Programme, are that the number of people in lower middle income countries that face acute food insecurity may well double to 265 million worldwide by the end of this year. That they estimate that there are 6.7 million children with wasting in this year on top of what had been projected if there would have not been any COVID-19. 58% of those in South Asia, almost a quarter in Sub-Saharan Africa, and they project almost 130,000 excess deaths in under 5 children during 2020 due to this, of which more than half is in Sub-Saharan Africa. So these are really scary numbers and huge impacts. There are also some positive impacts, not a lot, but there's definitely one I want to show to you. This is what happened in South Africa when they started the lockdown, which was not only a lockdown, but was also a ban on sales of alcohol. So what you see here is these are the expected rate of deaths from natural causes in the over 60, and you can see that during the lockdowns that remained more or less the same. But if you look at deaths from unnatural causes in all age groups, it clearly went down, and that was basically due to the fact that there were much fewer trauma deaths due to violence or traffic accidents. So let's look at the epidemic response. I hope still have some time. Now I'm showing you this slide because I think it's a very nice overview. It's from a recent Lancet paper that actually spells out what countries should be able to do, capable of doing in order to have a robust response in this stage of the epidemic. And I'll only mention here because it's basically about what the indicators would be, but I think these are the important ones. So a country should have ability to detect and break transmission change, to minimize deaths and severe complications, to minimize hospital-acquired COVID-19, so it's really about infection control. Have financial, maybe fiscal support for individuals and companies to ease the effects of the lockdowns. A guaranteed maintenance of food and medicine supply chains, protect and support their vulnerable and neglected populations, and guarantee maintenance of usual health services. Now, definitely not all countries have been able to do this. And this, I'm just showing that another thing that's tremendously important is obviously health communication. This is from a WHO publication. Now, if you look at the numbers, this is again from the Johns Hopkins Resource Center, you see some things that really show that there are clear differences between countries. Now, this gives you the cumulative number, total number, but obviously that is a reflection of countries' population sizes. Now, this is the same, it's also a reflection of population sizes, but this is why this is cumulative, this is sort of instantaneous, this is now, this is from last week, a 5-day moving average. And you see that whereas some countries, especially, or many countries, especially in the Americas and some in Europe, have high daily numbers, many countries like China, where it all started, other countries actually have pretty low daily numbers, and that's an interesting observation. Now, clearly you need to express that also you need to adjust that for population sizes, so you need to express that per, for example, here 100,000 population. This is what we've seen already. This is the deaths. I already pointed to this, what I find intriguing, these very high death rates in the Americas. For example, here we have Brazil, 64 per 100,000. I think that's pretty high. So this is cumulative over time. South Africa basically has only about half those numbers of deaths. And there may be underreporting, but I don't have the impression that there is huge underreporting in South Africa. Russia, much lower. India, much lower. That may actually be partly due to underreporting. If we look at numbers and how they, so this cumulative numbers per 100,000 population, how that changed over time, that's also interesting. Or rather what the cumulative number is over time and where we currently are. And this is just the number of countries that are on that Johns Hopkins site. Now, if you look here very much on top, so to me, there are three clear groups here. There's a group here, there's a group here, there's a group here. Now, the first group, that includes Peru, Brazil, the United States, has very high case rates, tremendously high, compared to the other ones. Then, pretty much lower, but still high, is this one here, that includes countries like Colombia, Argentina, but also Spain. And this is obviously much lower. I think here we have for a number of countries. I'm not sure about France, but I think there are quite some indication that, for example, for India and Russia, there is underreporting as of yet. If you put them together, you see a couple of patterns over time that probably, to a large extent, reflect the epidemic response. Now, there was one pattern here. This is for most European countries, and France here is the example. Of what you're looking at is the numbers of cases per 100,000. This is cumulative, and this is per day. So you can see that in these countries there was a clear outbreak in the early stage of the epidemic, March, April. That was responded on by lockdowns. The lockdowns led to a clear decrease in case numbers. And where the lockdowns were eased over summer, partly because of holiday travel, partly because schools and universities reopened, you see a real clear rise again. This is India. India had a lockdown for a very long time, started easing that in after May, and then it started really to go up. And for Brazil, I don't think there's been a consistent lockdown in all the states of Brazil. And you basically see that from a relatively early stage, it's really 1 month earlier than in India, you saw numbers go up, and you still see numbers quite high, but you'll be much more aware of that than I am. Zooming in a little bit on India, so they had a very strict lockdown right after the WHO declared COVID-19 to be a pandemic, which was the same was true for many African countries. Very few cases, but huge economic consequences. So they decided to sort of loosen the grip of the lockdowns. They had various phases, and this is the phase where schools opened, businesses opened, restaurants and bars opened, and then you really see it take off. Now, interest is there are some examples of countries that are not in that list of Hopkins, but that show pretty different patterns. Now, this is one that I find intriguing. This is Vietnam, a country I know well. It's not a small country, almost 100 million people. They looked at this paper from Clinical Infectious Diseases, where they looked at the first 100 days of their epidemic. They had only 270 cases and no deaths. And I know that they have a pretty solid, I did a lot of TB work there, pretty solid surveillance system. And the way they did this by having active monitoring of travelers at airports, schools and universities being closed, doing an awful lot of testing. So this is for 100 days in the beginning of the epidemic, 250,000 tests, PCR tests, and they quarantined 200,000 people. So once you had been in contact with an infectious case, you had to be quarantined. That was either at home or in military barracks. Actually, I had a PhD student who moved back from the Netherlands to Vietnam, who was for 2 weeks in military barracks. I asked him, isn't that terrible? He said, no, the food is much better. So much for Dutch food. And others they quarantined in hotels. They had a full lockdown, but only for 3 weeks here in this period in early April. They still don't have lockdowns, even though they see surges on numbers every now and then. So I think a combination of these kind of measures can sort of keep transmission down, even though it comes at considerable cost. And I think the interesting thing here would be to see what the costs are. If you look at their per capita GDP, so the economic, they don't have this economic decline that we are seeing in many other countries. They're one of the few countries that still expect to grow this year. So the big question is, do we really need to have lockdowns, or can we just avoid certain things? And I think there are now data getting out to answer this question. This is a very recent one from the CDC periodical that did a case control study of COVID-19 patients in 11 US health facilities that were all above 18 years old, and they had matched controls that had no COVID-19. And it's very interesting because what you see is that basically, so they looked at what sort of exposures they had, and the light blue line is after excluding those for which they knew they had a close contact to a COVID-19 patient. So this is probably the more reliable one. So shopping, being at home, being in an office setting, here, being on public transport, doesn't really increase your risk. Now, mind this is in a situation, obviously, we all know in the United States, not everyone wears their face mask. It's even along political division lines, but still, most people do such things. So this is against the background of these kind of containment measures. But then you see that going to restaurants, going to a gym, although that's not really statistically significant, going to bars and coffee shops and religious gatherings are the places where you can get infected. And that shows that social gatherings are really at the highest risk. By the way, they didn't make a distinction between in and outdoors. It would be interesting to see that. And the most intriguing paper is the one that came out last week in Nature Medicine. And this is this really great paper. You really should look it up. On that shows the contact tracing data on all 1,000 cases in the beginning of the epidemic in Hong Kong. And what they did, so they did contact tracing and they came up with 50 clusters. So it's just based on contact tracing information. And what they actually show is that there are a few very large clusters that basically drive this picture. And here, the yellow circles here are people who have been infected at social gatherings. And these ones here, the blue ones, is within the family, within the household. These ones are at work, and there's only one here during local travel. So it basically shows you that these social gatherings are really the engine of transmission in that situation. Now, this was in a situation where there was already quite a bit of quarantining. As you can see, these people were here quarantined when they, so that's why there's probably very little transmission from households. But continuing this is probably the way in which the epidemic is sustained. And they actually calculated only 19% of the cases seeded 80% of all transmissions. So it's a really skewed distribution. So that means if there's anything we can do, we have to avoid these social gatherings where things happen. And then, of course, a very interesting discussion as to how these transmissions occur, but I'll stay out of that for now. So finally, a few words about the vaccine. We've seen a lot of good news, and that's especially brought by this man here who is dependent on that for his re-election. We have seen truly tremendous investments made and financial pledges made by US government, European government, European Commission, others. And there are, as a result of that, 200 candidates in development. Clinical trials pathways have been accelerated, going down really to what normally would be years now being sort of accelerated to 6 months, 6 to 12 months only. For several candidates, immunogenicity in humans has been established. There are 4 candidates currently in phase 3 trials, large trials, all around 30,000 individuals, and results are expected by the end of the year. And if you listen to this person, they will come shortly before or after his re-election. But there were also concerns, and these concerns are, these are just a few of them, but these are the main ones. First of all, because of all this acceleration, we have very little animal model data. There is a little bit non-human primate data for some of the vaccines, including the Oxford one. But there is very little, which means that we have very little understanding of whether those immune responses that are shown in humans in the phase 1 trials, whether they actually reflect protection. To be honest, we don't know. And the problem there is that most candidates follow the same approach, which is to elicit antibodies to the spike protein. That's the one by which the virus enters the cell. But we are not really sure that that is what will work. So if that fails to protect, we're basically back at square one. And we don't know what efficacy can be expected or what level of efficacy can be expected. Obviously, you want a very high level of efficacy, as I will show. Another problem is that we know from the, we have little knowledge of SARS because there were so few people, but we know from the seasonal coronaviruses that antibody responses only remain for about a year. That's probably why we get them again after a year. So duration may actually be short. It may be that protection is longer, but then no non-neutralizing protection, which means that after a year you can get infected again, but it will mitigate severe disease. So you get infected with a mild disease, which has been shown actually in human transmission models for some of these seasonal coronaviruses. But it means, it implies, so it would in a sense be good news because we would avoid severe disease and death, but it means that there will be no herd immunity. So it means that you need a very high vaccine coverage with a very high efficacy to prevent further spread of this disease in people who are not protected. So this is a real difficult one. And it may actually be that all those accelerated trials are too small and too short to detect safety problems, especially rare toxicities that can be very severe, but also potential immune enhancement effects. Now, you are from a country that knows dengue hemorrhagic fever, so you know the immune enhancement theory. That we know that for some of the coronaviruses of animals, especially of cats, there can be these immune enhancement effects. So it may actually be that once your vaccine-induced antibodies start to wane, they may actually start to have an enhancement effect. And we have no clue whatsoever whether that's going to happen. And we will only know that if we follow up these patients in these trials for 2 years. But I can tell you, the current US president is not going to wait for that. So there is one other issue with these vaccines, or there are several other issues, but one issue that's, I think, is important for global health because it really circles back to the issue of disparities. First is that it has to do with the fact that several high-income countries, including mine, have signed up advanced purchase agreements, which means they have bought vaccine stocks up front. They just said, give me 30 million or give me 300 million. I'll just buy it. And the consequence of that is that we don't know currently how to ensure that there is enough vaccine for resource poor countries, because the rich countries are eating up all the vaccines when they become available. And the other thing is that how do we ensure funding for resource poor countries, not only to purchase those vaccines, but also to deliver those vaccines. And the WHO has started this initiative, the ACT Accelerator, where they try to bring in all sorts of other partners and also funders. They have now calculated they need $18 billion for a vaccine to really be able to do this. They now have a pledge of only $2 billion, so there's still a long way to go. And with that sobering remark, I would like to thank you for your attention. Sorry to be a bit over time, and happy to take any questions.
Thank you so much. Thank you, Frank, so much for your comprehensive and so interesting lecture today. We have 35 students online, and I am sure they have plenty of questions to pop. But before we give them the floor, I would like to introduce Eduardo Feinstein. He's the co-chair today. Eduardo is a full professor of epidemiology at the Social Medicine Institute at the State University of Rio de Janeiro. And he is the coordinator of the Brazil Center of Global Health. Eduardo, would you like to say anything before we give the floor to the students?
First of all, we have to thank you, Frank, for such a complete, comprehensive, and updated talk. But let me thank you so much. I hope we will meet again in either in Amsterdam, in Rio, or through Zoom. Let's see what happens next. But I have questions, if I can. There are two concepts I would like to comment on. First, the idea of this movement of One Health. Do you think it will help science and public health science and global health to see things in a more comprehensive way from now on, given the circumstances of this current pandemic? And second, there is a concept that was brought to the field by an anthropologist, Singer, called syndemics. And apparently obesity and COVID-19 they would fit into such a concept, mainly thinking about mortality. So would you comment on these two issues, please?
Yes, yes. Thank you, Eduardo, and also thank you for your kind words. And definitely, it would be great to meet at some point in time again, just in the flesh and being able to embrace one another again. I think that's the thing that we are currently missing most. And so I think these are excellent questions. So you're absolutely right. I think the One Health concept is tremendously important. And it is tremendously important for the next, basically our next epidemic. And I think we are perhaps late now, but I think and I think if you look at for example, this global health security agenda, which was started by President Obama after the Ebola outbreak in West Africa, which brought quite a large number of countries together, basically to prevent another such occurrence, but also to strengthen the epidemic response capabilities. That is very much based on the One Health on the One Health principle, which basically is that human health, animal health, and environmental health should be seen as a whole and should be looked at in their mutual association. We are currently not, and I'm not really into One Health. I have one colleague who's doing quite a bit of that work in the field of antimicrobial resistance, where indeed they try to, for example, look, and it's just as an example how that could work, where, for example, they look at antimicrobial resistance in enteric pathogens, both in humans and in their livestock. That is just one example. And to see what the sequence of events is there, how the spread is, where there is a possible amplification, in which species there is possible amplification of that resistance and so on, and in which resistance genes might be exchanged, those kind of questions. So I think this is a really very important way of studying the potential for outbreak in various settings, because that's the first thing we need. We need to avoid that as much as we can, but also to have a much better, much stronger capabilities in countries to have an early epidemic response. And with regard to your second question, the syndemics, I think that's a very, very interesting one, because we work with our anthropologists in our department, actually in our institute, actually quite a bit on syndemics. It's really an area that they've been pushing, and I think COVID-19. I mean, thinking back about that one slide about reinforcing disparities, is, I think, very much about the concept of syndemics, and I think the syndemics framework, I think, is a very, very useful framework for analyzing these kind of complex interactions between them. And I think one of the big questions, for example, to what extent are these ethnic disparities that we see, to what extent are these related to these many sort of potential underlying associations, is definitely one that could be looked at through a syndemics lens. So thank you for that suggestion. I'm going to bring it up with my fellow anthropologists in the institute.
So the students want to pop any question? Frank, what do you think? Some ecological studies have shown that maybe BCG protects the population. Some of them, of course, were very bad quality studies that did not control, adjust for many other possible covariates, but some studies are quite convincing. What do you think about that?
Well, first of all, I think that talking to you, there's no way to escape a TB question. So I think in principle, so there is, I think there is quite some evidence to suggest that BCG has these non-specific effects. We've seen there's been these studies from Guinea-Bissau by Peter Orby's group and several others. And there have been also been data for other live attenuated vaccines, but I think the fact that it is a live attenuated vaccine probably matters, that have similar, perhaps not to the same extent, but similar non-specific effects on the incidence of especially viral diseases. Now we know that, for example, for OPV, and there's been suggestions for measles vaccine as well. There's been actually a very interesting paper out lately. No, that was already out, I think, last year, that had shown that BCG vaccination, or at least suggested BCG vaccination, had an effect on, and that was recent vaccination, had an effect on the incidence of respiratory viral infections, so not about COVID-19, but other respiratory viral infections in the elderly, probably by some sort of boosting of their immunity. And you're obviously aware of the discussions around the mechanism, which may actually be a mechanism through innate immunity. This whole concept of trained innate immunity that's now very much en vogue, which has to do with what's it called again? Epigenomic regulation of not T cells, but it's late, not monocytes, but macrophages. Sorry. Now working to me, and I can't remember the term macrophage. So yes, I think there is potential biological basis. I'm not sure that indeed that all the epidemiological studies are very helpful here to tease this out, because some of them are about effects that are many years after BCG vaccination. I think that is a difficult case to make. It's also a kind of these are kinds of analyses in which you very easily, as you already alluded to, may have all sorts of uncontrolled confounding. So I think the evidence really has to come from the trials. There's a couple of trials now ongoing that try to see whether BCG vaccination will have a positive effect. I think in the beginning there were some concerns that if you give BCG vaccination to people who are at that point in time incubating COVID-19, that you may actually worsen things because you may stir up their cellular immunity, which probably plays a role in the cytokine storm, which is probably underlying this idea of viral sepsis. But it doesn't seem that I don't know of any of these trials, and they've been going on for a while, that they have been stopped for safety reasons. So this is probably not a big issue. I know the biggest trial that's currently ongoing on this question is ongoing in Australia with funding by the Bill and Melinda Gates Foundation.
And in Brazil.
Yeah, and there's also one there. Yeah, and I think the mere fact that the Gates Foundation investing in that is that they probably believe that there is something there. And I think we're going to see the results of the first trials in the coming months. So it's going to be exciting. My hunch is, but obviously we have to wait what comes out of it, that there will be an effect, that there will be mitigating effect on severity of disease, but that it will still be relatively small, even though I don't know what the trial looks like in Brazil, but most of the trials thus far are in relatively young adults, because they're very often in healthcare workers. And obviously the ones you want to protect are the elderly and the ones with the comorbidities. So they may not be the same populations, but we'll see.
And we have two national trials on BCG going on here. Well, they have not started, but they are funded. and there is also one arm of the Australian study here. I have another question before the questions are coming up.
Sure.
You talked about your concern on the distribution of the vaccine in the world and the possibility of acquisition of the vaccine for the poor resource countries. What do you think about the cold chain that is needed for the distribution of the vaccine? How do you see that in Africa, in countries that you know so well?
Well, I think the big problem, and there's been quite a bit of thinking around that, because I mean, also from the perspective of tuberculosis vaccines, because this is a vaccine that you basically, so I think the population you want to vaccinate, that you want to start with, is definitely not a population that would normally be vaccinated in expanded programs and immunization, which is infants and young children. You want to start with the ones that are most at risk, and that's the elderly, and that's adults with comorbidities, which means that you have to have a completely different way of delivering your vaccines. And there is very little experience with that apart from influenza vaccines, and now of course we have the shingle vaccine in the elderly. We have in adolescents we have the HPV vaccine, but those are the only examples we currently have. And especially if you need to do large campaigns, then I think indeed cold chain requirements are always critical. But having said that, we know from other vaccines in which large mop-up campaigns are being done, for example, measles vaccination, that is also definitely a vaccine that is temperature critical. So for that you also need cold chain. So maybe cold chain is not so much the most important thing. To me, the most important thing is, there was actually a picture showing this, but I didn't comment on that. My main concern here is the anti-vax movement, to be very honest, this acceptance of vaccination, which is going to be very hard, especially if this is going to be a vaccine that has some side effects, and especially if this is, or for which the side effects are not sufficiently known, and especially if this is a vaccine that has incomplete efficacy, which I expect is going to happen. And then that can be very, very difficult. And obviously we know that in poor countries, vaccine hesitancy doesn't really have a stronghold yet. But at some point in time it will come. It will definitely be a problem for, I don't know about Brazil and other countries in South America, but it's definitely going to be a problem in Europe and in the United States.
So there's one student asking you to comment a little bit on dengue and COVID. Do you have any information to share with us?
To be honest, no. I don't know of any clinical interactions. There may be, I don't know. They're pretty different. They're different virus types. One is a flavivirus, the other one obviously is a coronavirus. They are quite different in their pathology. They're different in their transmission. So I don't know, to be honest. The only thing, as I already mentioned, where there is a potential association or similarity between the two is the potential for antibody-dependent enhancement. So, meaning that existing antibodies actually can have a deleterious effect.
Martha, do you want to explain, clarify what you had in mind?
Yes, I will try. Sorry for my English. But anyway, it's because a paper that was recently released by Marco Nacolelis, and he found, and it was a surprise for him, that in areas that dengue was very prevalent, or well, better, where a high incidence, the incidence of COVID, of SARS-CoV was low. So it's a kind of inversion. And it was a very difficult paper to read for me. And then later I I by chance I read some comments of him saying, as I said, that it was a surprise. He doesn't know really what is the clinical impact of that, but they made at the same time of dengue and COVID, and they found that. So that's why I asked it, because he couldn't quite explain, because they were, as you said, very different, but it happened. And and that's why I asked it, because it was really a very difficult paper for me, and I couldn't quite draw any conclusion of that. So that's why.
Thank you. I think it's a very interesting question, and it shows that, I mean, I don't try to keep up the entire literature for COVID-19, but it's like I think 3,000 papers a day or something. So I obviously missed this one. I think it is. I mean, it's definitely an interesting observation. There have been other observations also of these negative associations. I think one of the difficulties, but I haven't seen it, so I don't know exactly how they did it. But just thinking about it as an infectious disease epidemiologist, what you then generally do is that you look at associations between segments of the population, for example, a district or a neighborhood, and you compare those neighborhoods, you compare the rates for one disease and the other disease in the neighborhoods, which means that you have some sort of an ecological analysis, that's what we call in epidemiology, ecological analysis. And ecological analyses are also always a bit, they're easily susceptible to what is called the confounding fallacy. So the ecological fallacy. So you can actually miss all sorts of confounders that are, there's all sorts of sort of underlying factors that are there at the level of the individual. That is because at the group level they are sort of averaged out, and that may mean that you can actually may fail to adjust for those kinds of effects. But it would be great to see the paper, so I'll look it up. It should be easy to find because there will be very few papers on COVID-19 and dengue. Never try COVID-19 and hypertension, because it's not undoable. It would be great to look into, yeah.
Thank you. Yes, I will put here the reference, and
Yeah.
it will be great. Thank you. Thank you.
Yeah. Thanks.
Mayara.
Always mute. Good afternoon. I am a student.
We can't hear you.
Can you hear me now? Sorry.
No.
Can you hear me now? Or?
More or less.
Better?
Yeah, that's better now.
Okay. So good afternoon. My name is Mara Bastos. I'm a EPI student. So my question is about expanding testing. We heard like from WHO since the beginning of the epidemic that test is like the most important strategy to contain the epidemic. But now we have seen, like, for example, places as Alberta in Canada or UK, the expanding testing for asymptomatic is becoming problematic. Even the test has higher specificity. If you test millions of people, you're gonna end in to have like millions of false positives. And so what's the trade? Like how much we should test, who we should test? Because if we start to having like a lot of false positives, you're gonna put a lot of people in isolation, and it's a huge problem for the economy, for families, and whatever, and other issues. And even like Alberta, like they tested millions of people, and then for at each 1,000 of people tested, they found 7 positive COVID. So who, when, how many people we should test to control the epidemic? That's my opinion. I think it's a very difficult question to answer, but I just would like to hear your
Yeah, it's a great question, but I can't give you the sort of the numbers, but what I give you would be my considerations. So my consideration, first of all, is that it depends on what you want to test for. So I think the testing that you refer to is population testing. So
Yeah.
you basically do that to block transmission. That's what you want to do. You want to find people who need to be quarantined. That's basically what you want to do.
Yes, yes.
Yeah. So, and I think what we have been, and I think that that requires or can be done with a different kind of test than the test that you would need for individual diagnosis. So if a patient comes in a hospital and has symptoms that are compatible with COVID, you want to make sure that the patient has COVID. You want to have a test with a high sensitivity. You don't care too much about specificity. So that's what the RT-PCR does. Yes? And of course, you can get a quantitative readout looking at CT values and so on. Now we know that the very high, and I think it is above CT values of 24, but I don't know the number exactly. Above that, you will probably still have, or the specificity becomes very low above those very high CT values, which means that there is a very low viral load that it shows. Okay, now we also know that those patients are not infectious. There's basically too few. There is not much direct evidence, but there's enough indirect evidence, I think, to show that they are not infectious. So it means that you're only interested from a perspective of transmission blocking, you're only interested in the ones that have relatively high viral loads. And that can thus be found by a test with lower sensitivity. And for any test, unless you have a very bad test, but for any test, sensitivity and specificity is always a trade-off. You probably know the famous ROC curve. So you can basically tweak your test threshold if it would be an PCR, but also it would be an antigen test, because antigen tests are now coming to the market in such a way that there's high sensitivity, high specificity, not necessarily high sensitivity. So I think the hope is now for antigen tests that are capable of showing with sufficient of detecting with sufficient sensitivity those people who are really infectious and not finding the ones that are sort of under the radar, that are infected but not infectious to others, without losing too much specificity, so that you don't run into that problem of false positives, large numbers of false positives, which you will get if you start testing asymptomatics. So my perfect test scenario looks like this. You have a test which is an antigen test, which gives you a result in a half hour. Can actually be sold over the counter at drugstores. Maybe you can even mail it to people if the mail still functions. That test is not good as a diagnostic test, but it's good enough as a test to detect people who have high viral loads and are infectious. That test, and that should be like a $1 or maybe $0.50 test. That test is being used in everyone who has known contact with someone who has COVID and tested regularly, because just testing once doesn't tell you an awful lot. It's also used, for example, and this is what I don't know if you've been following the discussion in the United States, the famous what's now called the Michael Minna discussion. That's the guy the epidemiologist who suggested this. That can also be used at, for example, schools and universities. If you test regularly, you will take out most of the infectious cases and avoid those super spreading events, as they're called. And so that would be my perfect scenario. An antigen test, so not a PCR test, but an antigen test, cheap, simple, good enough sensitivity for high levels of viremia with good specificity. Is that an answer to your question?
Yeah. UK is having like the huge discussion now. The epidemiologists are coming for this because they're trying to test the whole population. So the epidemiologists and biostats in UK saying don't do it. We need to decide we need to test. and not like testing everyone. And
Yeah, I mean, testing a whole population with an antigen test doesn't really make sense because first of all, it's a snapshot. So it doesn't really make sense. So you have to link it somehow to either having been at risk or posing a particular risk.
exactly, yeah.
And there are ways of doing that. I mean, you can look at what the current spread in the population is. If you have a sort of real-time contact trace, you can have an idea about that and then target those tests. But it's a tremendously important question because until we have a vaccine, that's probably the only way in which we are going to be effective.
Okay. Thank you.
Eduardo.
Okay, just want to call your attention. Just minutes ago, I got this Nature magazine briefing. They send me, every other day. I don't know. And just incidentally, let me mention that they say, "Hello, Nature readers. Today we hear that Arctic sea ice has hit another shocking low." Then they say, "And learn what happened in a city where COVID-19 raged almost unchecked." That's Manaus in Brazil. So, and not by chance, that's the highlights of these today's Nature briefing: the Arctic melting down and the COVID-19 pandemic. So that adds to the complexity that Frank was talking to us so brilliantly.
I got it. The city of Manaus, Brazil might help to reveal what the terrible toll of coronavirus looks like when the virus rages almost unchecked.
Yes.
Yep, it's the MIT Technology Review. I have the same subscription as you have. I haven't seen it yet.
Yes, that's right.
It's good, eh? It's good, Nature briefings. It's really highly recommendable.
Mm-hmm. Well, if nobody else has questions, I'll thank so much Frank. It's late in the Netherlands. I think he has the right for a little bit of rest. Thank you so much for this wonderful lecture. Very comprehensive, very, very informative, and very, it makes us wonder a lot. So I also hope we'll be able to hug again very soon. And thank you so much, Frank.
It's been my pleasure, and I hope to see you at some other point in time in either through Zoom, but indeed, hopefully, person to person.
Hopefully.
Okay.
Bye.
Bye-bye.
It was wonderful.
Bye.
Thank you.
Bye-bye.
Thank you very much.
My pleasure. Bye-bye.
Bye.